So the idea is that we can, we can come up with all these things. I just realized I forgot to record. So let me just go back. So we have team 1, which is the peer support group that provides basically support in several languages. We have the convalescent plasma donation team, which is team 2. We have the coronavirus fighter app team, which is team 3, which is going to come up with that app that is going to ensure that people are monitored, and also that they can keep their quarantine, and that they can maybe donate plasma. Then we have team 4, which is basically a clinical guidance team. Team 5, which is a volunteer engagement team, as I told you, which basically is going to engage volunteers and put them in the right categories. So team 6 is a national registry, which basically, as you know, what happens with this virus is the healthcare providers are the first to get sick. So they get sick, and then they either get sicker or they have to be out for 14 days. So what happens with our nurses, respiratory therapists, when we're at the peak of the pandemic and we're having issues with staffing? So the idea of this team is to create a registry of people that in Miami or in the Philippines or wherever it is in the world, that people can register to the site, and they can say, okay, I am a nurse. I live 10 minutes from Manila. I'm retired, but I'm not afraid of COVID. I'm willing to come in and help. That's the purpose of that team. Everybody, please mute your phones if you just joined us. Then we have a team 7, which is basically like an engagement team for convalescent plasma. So their only job is to go on TV and radio stations and actually seek out people that were tested. So not the people that we've tested, but the people that were tested in the public laboratories. And their job is to just put out the word in English, Spanish, and Creole, which are languages that are spoken in Miami, and say, if you became positive, you can save 3 lives. If you don't have any symptoms, we can bring you in for a convalescent plasma donation. And then we have team 8, which basically takes those leads, makes sure that they have requisites, which is a copy of the positive COVID and the time frame, and then send them to team 2, which is the one that actually closes the deal with the blood bank. So we have it really broken down. And then we have a team 9, which is a discharge recovery team. So if you're in the hospital, this is a different group. So if you're in the hospital, you're discharged from the hospital. The purpose of this team is to make sure that people that are discharged from the hospital get proper follow-up. One of the things we saw in the Chinese data was that people were getting sick after they got discharged. And the people were saying, well, maybe they're getting the virus again. It wasn't that they got the virus again. It was that basically they never really got the virus out. And so it's very important to follow those people with pulse oximetry and different techniques. And that's not really being done on a routine basis. So that's the purpose of that team. And then team 10, which I think is the best team of all, because basically the purpose of this team, yeah. Everybody muting?
Yeah.
Okay, make sure you mute. So the purpose of team 10 is actually to break the chain, and basically to hopefully with the use of the app, once the app is deployed, maybe we can each in our geographic area develop a team of people. The app will be free, nationally or internationally. And the idea is that with proper training, we can each either recruit people or teach people or ourselves follow people that in order to do the contact tracing and stop the spread of this virus. The estimate from the CDC is that the United States alone needs 100,000 tracers in order to stop to come to anywhere close to controlling this virus. So if the United States needs 100,000 people, can you imagine how many people you need in each country that's represented here? And the idea is, this is not a United States thing. We're doing this for everybody. And the idea is that they can copy this and hopefully emulate it. And that's the point. And I mean, I think we get really lucky that, in this particular team, Dr. Okoli was at MPH. Do you want to tell me a little bit about yourself, Dr. Okoli? Maybe you're muted.
It's on. Yeah. Hello, everyone.
Can you hear me?
Yeah, I can hear you. We can hear you.
Yeah,
Okay.
we can hear you.
Oh, awesome. Well, so my
Yeah,
name
we
is
can
Dr.
hear you.
Koya. I started my career in rural Nigeria as a public health physician about 11 years ago. I moved to the United States for a medical education fellowship with the Association of American Medical Colleges in 2012. So currently, I live in the Bay Area, and I just serve as a consultant with some of the pharmaceutical companies here, then with the UCSF too. So, and looking forward to learning from the group and working together. Thank you. You're still on mode, Dr. Michelle. I think you're on mode.
Oh, yes, yes. Do you want to start sharing?
Let me
Sorry,
show you a mod.
do you want to start sharing the material that you prepared so that everybody's aware of what of that folder and what the contents are? Did everybody fill the survey?
Yes, yes. We had a very the response was really very remarkable. I think we already have 50 people, or 49 or 50 people complete the survey. And so we're looking forward, everyone, if you don't have the link, I'll just post the link on the chat. And we just go ahead and complete it so that we'll understand where the needs are and what your preferences are. And Karim will be leading the WhatsApp group. And, so please share your phone numbers. And if you have a different WhatsApp, number, please share with us. And I'll share that information with Karim so that, he will create a group and we will take it from there.
Do you want to share on your screen because maybe some people didn't get to see the what you put up? Can you do it on your screen? Just go through what the way that we're going to come up with the protocols and all that.
Okay, give me 1 second. Let me get to that drive.
No problem. Take your time.
Yeah. And I'll be posting it quickly on the chat so that everybody could get to that too. 1 second.
Yeah, we do have Camilo, we do have a Google, it's in a Google Drive. Actually, Doctor, you want to share that on the screen? Yeah, I think everybody has it.
Yeah, so I just shared the link via chat. Give me 1 second. Let me pull up the drive so that everybody will have that. Or you could probably check your emails for some of this information. And I know there's been some questions, and and I will share that quickly with some of those with Dr. Mitchell so that he will help us answer those. If you have more questions, just please just put them on the chat right now so that I could read it out so that Dr. Mitchell could help us address some of those.
Okay, and the concept here is obviously none of this is really perfect. I think you guys can kind of make this whatever you want it to be. I think we need to come up with a strategy so that it's not just 50 of us, because I don't think 50 people are going to fix this problem. So I think we need to find kind of a way to get more people engaged and then keep everybody their description of what they do. I think the app is going to be huge in allowing us to do this type of work as contact tracers. Because as long as we're organized and we have that Ebola guidance,
Yes.
So hopefully we can use some of that to adapt it to what we need to do. But I could give you some examples of how it's failing. So the first day we had testing, we tested a group of two Mexican tourists. So they basically came for testing. And at the time we were saying that only people that were symptomatic could be tested. So obviously they lied because they were not symptomatic. And so when we called them, we said, you're positive. Both of them were positive. And they said, well, so we said, why are you have no symptoms? Why did you get tested? And they said, well, we were at this lunch with 10 other people. And two of the people in that table were positive. So I could tell you based on the way this virus behaves, 100% of the people on that table had the virus. Somehow these close gatherings, whether it's a birthday party, or whether it's, if you have 10 people, 12, everybody in the room is going to get it. I don't know how it does it, if it's through the hands and people put their hands in their face, something, but I can tell you the other 6 had it. We couldn't find them because by the time, so we called the Mexican tourists and we said, can you give us the names of the people? They said, oh yeah, I can get it for you. But then we gave it to the health department. The health department just basically did nothing with the information. And then 3 days later, they called us, they said, we can't find them anymore. Well, they were gone. So now we got 6 people. Who knows how many people those people gave it to? So that's the type of stuff that I think a group like this needs to think about. This is more like investigative work. We had a couple. I'm just telling you the stories of the people that we've tested. So there was a couple that came from Canada. They came from Canada, and then obviously they had the virus. They had been in Europe before. So they come from Canada. They stop in North Carolina for a week or two. Then they stop in Disney World for a week or two. I mean, who knows how many people got it there. Somebody, everybody mute? Okay. And then they came to Miami. In Miami, one of our police officers served them with a warrant about something that had happened. So the police officer said the lady was sneezing, and the only reason he wanted to get tested, he had no symptoms. He was positive. So who knows, that just that one family alone, it just tells you the extent of this. So when we ask the question, we have to think about stuff like that, because people don't think about that. And as you know, the transmission is mostly in the family. So Junior goes in a party with his friends next door. One of those friends has a virus. He gives it to Junior. Junior comes in the house. He gives it to grandma, to grandpa, to daddy, to mommy, to every sister in the house. Everybody gets it. So that's how this is transmitted. Anyway, Okoli, were you able to get the stuff up? Doctor? Dr. Okoye, can you hear me?
So I just unmuted. Yeah, sorry about that. So,
no,
so I shared that on the chat. I don't know if people were able to see the folders. We could all go to the folder and just see what we have there. Uploaded information on Ebola, Dr. Michel talked about. I only uploaded information from the European Union on some of the resources that are needed. Areas around, the planning phase, the operational phase, things will be needing training, setting up call centers if that's necessary, the entire strategy. So we have to figure a way to get ourselves into group. I know we have, various skill sets, so I'll be sharing maybe a more extensive survey. I expect collaborators, people that, could join and, for us to design a strategy. I really look forward to, working with everyone, look forward to a positive experience, right? And like I said, I'm seeing some of the questions right now. Can we upload a file in the drive where everybody can add their WhatsApp number? Yeah, we already did that, but thanks for sharing your WhatsApp numbers. Karum will be leading that aspect, and it will be up shortly, right? And Dr. Mitchell, they have questions about the framework. I don't know if you want to talk a little bit around, the work framework, just setting tone generally for this team.
I think we need to kind of figure out, I think your idea of doing it by regions makes a lot of sense.
Okay.
So I think what we need to, it's my opinion, but I mean, obviously this is open to everybody giving their opinion, and by no means do I know all the answers, but I think we need to have regional people that are best equipped, and then basically just have like a regional meeting, which, because we could maybe do 100, maybe 1,000 people on this Zoom, but I don't think we're not going to be able to ever do 10,000 people. So we need to basically have people that we think are well positioned in their particular area that can just take information from the group and then say, okay, well, this is what we're implementing. This worked. Once it's implemented, we might say, you know what, the app's not working because there's this particular feature that could benefit the app. I give you an example. Yesterday on the discharge group, that team 9, we were talking about discharge, what happened to discharge patients, and there was somebody from the UK. She said, wait, you're not discharging them with a pulse oximeter? I said, no. He says, well, in the UK, we find these cheap pulse oximeters, and we give them a pulse oximeter, and then because if the pulse oximeter drops, then they need to go back to the hospital. So that sounds like a very simple thing, but I can tell you no U.S. hospitals discharging people with pulse oximeters. So those are the types of things that can save lives. So we need to kind of also on the road be willing to kind of change things and adapt. So I guess having said that, how do you think we can organize this? I guess you're getting a geographic list of people. Is that what's happening now?
Yeah, yes, we're just getting a sense of where the needs are, and putting things together. I will send out a more extensive survey to gather that information. I want to minimize the number of emails we send so that people won't get overwhelmed. It's not a large group now, but it's going to get really large pretty quickly.
Yeah.
So
we will, before we end, I do want to, I want everybody to kind of introduce themselves, but I'll do it in order so that we don't talk over each other. Dr. Rana, what was that question about the COVID guideline? Dr. Rana?
Yeah, I'm here.
What do you mean by that?
Okay, so I just meant that we don't have a guideline yet by CDC or WHO, like how we are following an Ebola guideline.
I don't think there's anything out there. Dr. Koya, do you know if there's any standard contact tracing guideline for this? I don't think so.
No. So my knowledge, just the two I saw from the European Union, I uploaded those information, but I think we'll have to work on getting a standardized script for our team and, a standard protocol, a standard guideline that we'll be using. I think we need to, have groups, more like subject matters experts in maybe each category training, working on drafting scripts and standardized, guideline or protocol for volunteers. And so I don't know. I just uploaded what I saw, random Google search, not in big. Yeah.
Okay, thank you.
And everybody's free to upload stuff into that Google Drive, by the way,
Yes.
whether it's things that we can change. And so what do you think, Dr. Koya, should we just ask people to give their name, where they're from, or where they're at right now, so where they're located right now, and if they're a physician, nurse, a community organizer, is that a good idea? Does everybody want to do that?
Yeah. So Farah reached out to me this morning. She already had she's working on a group in Montana, and you probably mentioned that you read an article about the local coordinator in that region. So we need to work with people because we don't want to duplicate effort. We need to arrange our teams, then collaborate with people that are already working in those regions. And so it is, we have to get comfortable working with ambiguity because, this is a planning phase, a lot of information. So we have to equally try and streamline those information. So right. Yes.
And one thing is, that particular lady that you're mentioning there in Montana, I looked up, she does a video every single day. Okay. She actually calls herself a COVID outreach person, or so she has a name, like
Wow.
Whatever the title was. And I've never heard anybody in the United States do that.
Right.
So obviously she takes it seriously, and she's reporting her numbers daily. I can tell you how, like in Miami, for example, we were reporting our numbers daily, and the newspapers, not the newspapers, but some of the radio stations were saying, oh, you shouldn't be doing that. You shouldn't be scaring the public, telling them how many people are infected. We're like, I think people need to know, because if they don't know, they're going to get infected. So, but that's the type of attitude, and unfortunately, it's political. It's when the politicians, you know, who are mostly now demagogues, and they're basically just saying, you know, nothing's wrong, nothing's wrong, nothing's wrong, and I think people are believing it, and they're saying, oh, you're just scaring people, and we don't want to scare people. We just don't want people to die necessarily. Yesterday, 2 weekends ago, and these are the type of patterns you're going to find. So 2 weekends ago, we find out that we had 2 people that were infected in 2 separate funeral homes. And the only thing they had in common is they went to a funeral.
Oh.
So I called the mayor. I said, look, we need to stop these funeral things. Oh, he said, the president said 10 people. I said, I don't think the virus listens to what the president says. So I think 10 people is too many people to be in a funeral. And I think that needs to stop, because that's how people are. I got 2 people 2 weekends ago that got the disease from attending a funeral. So maybe we should not go attend funerals anymore. This virus doesn't listen to the president. So that's the type of stuff that's happening. And it's not, by the way, I'm not political in any way. This is science. This is not politics. I think we just need to put the science back in where it belongs, you know. But, right, so right.
Yeah, so that's correct, Dr. Mitchell. Gita just has a question. So should we coordinate with the local hospitals to give data about positive cases to follow up? You know, HIPAA, confidentiality issues, you know, so there, we just wanted to hear your insight on, you know, that strategy.
Okay, so let me tell you what we've done. So if you come to our drive-through, there's a release form that you sign, and that release form allows us to give them to you. Basically, it says that your information will be shared with community organizers and other people that will support you and help you. You can say you don't want to, but I can tell you 100% of the people don't have an issue with that. Now, some hospitals are going to not want to help you. And I think the way is, you know, when that happens, you go directly to the market, right? So I think if you just appeal to the people that are positive, they will call you. And once they call you, there's no issue with confidentiality, because they're calling you because they're positive and they need help. I think the app is huge, because this lady in Montana, for example, I can see how she could use the app, because she was saying, well, I'm doing this and I'm doing that, and I have these people following these other people. But if people have the app, I'm having caseworkers call them twice a day. Now you can imagine if you have, I don't know, 10,000 people that are COVID positive, and you're going to call them twice a day. You know how many people you need to do that? And what if they're not there? What if they were there in the bathroom and they didn't get the call? Right. But maybe they're short of breath. So the app is huge, because the app, it's free. And then if you don't press twice a day your symptoms, then that would generate a call or a reminder. But most of the people, if they do it within a certain time frame, you don't have to worry about those people anymore. So I think we need to think the technology, you know, how we can use technology.
Yeah, that's great. Thank you so much for that insight. And we have another question from Camille, and she's asking, are we creating a new app or getting it from other countries like Korea or Taiwan?
Yeah, so we got the Korean app thanks to the Korean government, and we're kind of adapted it to our use here. So we have, you know, they had like agents, we're calling them community outreach people. And basically it has the ability right now. So we plan to deploy towards the end of the month. Actually, I was going to give it to the lady in Montana because she's tracking like 35 people, just to see how it works in real life, you know, because there's no harm to downloading an app and using it. Right. But the idea is, because maybe we could figure out what the kinks are. Right. But so it has all the features that the Korean app has, except that obviously, you know, if you leave your quarantine area, quote unquote, you don't get arrested, but maybe you get a warning in your phone. Like, the warning you get on your phone sometimes when like Amber Alert or something, and it says, be careful, you could be risking other people or something like that, but we're not going to arrest you. But at least there'll be something to remind you to exercise caution. But we're more interested in the twice daily reporting, and eventually those people also volunteering. We have actually at least 10 positive people that are COVID positive that are in these groups already that want to help out.
Awesome. Well, thank you so much for that insight.
What's the app called?
Yeah, go ahead, Dr. Mitchell.
It's called we're thinking about coronavirus fighter app or COVID fighter app. What do you guys think about that?
Okay. Yeah. So please type in your recommendations in the chat about what you think about the app, the name. Dr. Mitchell is thinking about what we should call it, coronavirus fighter app, or other suggestions you might have. Please put that in on the chat.
Ikra is talking about how they have a lot. It seems like you have a lot of people working on it. Do they have a guideline or a form that they're using?
Yeah, we have a guideline. Actually, we are followed. Mr. Jack, listen to me.
Yeah.
I don't listen. Actually, we are in Pakistan. We have basically a unit which is working for this contact tracing policy. Beautiful. They actually guiding by the WHO and the European guideline, which already provided, already aware. So we are working on this. On this, we have to make a team of 4 or 3 members. There are 3 members. Actually, they have the contacts of these positive cases, and they follow them. And they have the form and the follow form and the supervise all these.
Ikra, can we steal those forms from you?
Yeah.
We need those forms. We'd love to adapt those for everybody. Is that okay, or are those private forms?
No. Jack, are you listen to me?
We can't hear you.
Yeah. So we are working actually on this unit policy for tracing contacts to reduce the transmission of that coronavirus, especially in all over the Pakistan. And this is actually making by the health department, which is leading to that, all with union councils members, district officers in this one, and some also administrative officer like some policemen, sub-commissioners, officers. They are also involved in this one to arrange all this one.
So I get the process, but do you have the forms? Do you have the actual tools that they're using that you can share with us?
Yeah.
Okay.
We have actually all the form. We have actually form for that. We have follow form for that. We have actually already arranged, but it is by the government level. They are making on this one.
No, if we can share, you know what? The South Korean app is amazing. We probably, it would have taken us 6 months to develop an app on our own. So just using their information.
So Baba said he could try and get the forms from the country. Is that something you could upload on a shared folder?
Yeah.
Awesome.
Beautiful. Someone's asking about the legal aspect of the app and personal data. There will be a release that like terms of use, conditions of use, and they will include the fact that obviously their data is going to be shared with people that are not necessarily physicians, and that this is part of what they're agreeing to in order to use the service. It's like anything else. I mean, somebody could end up with this information that may have some issue. We can't. I can see 100 things that could possibly happen in maybe 1% of the cases, but I think there's some things that you need to take some risks on. I do think that maybe we will have to have some type of the vetting procedure for who's an agent. Like, for example, we don't want an agent to be someone who's a sexual predator or somebody who, has a trouble with the law, that is a convict or something. So we need to obviously have some minimal, and I say minimal with a purpose. I mean, obviously, if you're in good standing, if you've never been arrested, if you, especially if you're a medical provider, but if you're a community organizer, there's no reason why you can't also be, we need everybody right now. So that's another question I have for the group is we need to come up with a list of who's qualified for this? Do we run a police background check? I don't think so, because I mean, if we do that, that's gonna be really expensive. I don't think we have money to run a background check on everybody that we're gonna, but I think we should have some minimal, qualification.
Yes, absolutely. We need some kind a way to vet most of our volunteers, and human resource management will be key, right? So that's it appears from what from this interaction, it appears that we're going to center everything around this app. The app, that's the major resource we'll be using. Because what I've seen, if you're outreach programs, like we have a call center or a central call center where everybody calls in, but it appears those will be solved with this app. The app, we get our data about patients from this app, we'll call them from this app, and they could equally call in. Can you walk us through that process, or how it's going to,
I'm sorry, was that a question?
Yeah, to make sure, I was just trying to understand how, because it appears the main resource will be the app, or do we have other foundational resources that we'll be using apart from this app?
I don't know. I mean, I'm open to whatever suggestions you have. I think the app is kind of the easiest thing, because it's if it works well, I think it could be our biggest tool. Obviously, we're going to have to think of the integration of the contact tracing with that app. And I don't know, I mean, that's something that's going to be work in progress, because I think ideally we want to do things electronically and document it, as opposed to, writing things down in pieces of paper or having files somewhere, or being in my computer file, but not in your computer file. I think maybe we need like some type of a central repository where all of this information is kept, and everything that we're doing is kind of documented. I don't know how people feel about that, but I think the more we make it standardized and we make it, transparent, the better it is. But
absolutely. And within your facility, do you have such resources that we could leverage? Or people. Do we have already something in place that we could leverage, or this is all still work in progress?
Well, we have both. I mean, we have with the app, we have a whole team of developers working on it right now, and they're available to make any changes to it. But we have, obviously, the hospitals have IT people that can help. So whatever resource you need, I mean, if you let me know, I can probably leverage it.
Awesome. We'll walk around that, and we'll be, just sharing additional information on the resource, some of the key resources the team will need. Yeah, I think there was still a couple of questions. I don't know if you want to take them.
Yeah. How many participants are we expecting per region? I mean, the number is for the U.S. is like 100,000 people. I don't know how they come up with the number, but I think it kind of has to be gauged by how many people they're following. And I think and yes, I think you can recruit your own volunteers, maybe not make him a member of the group, but if you're the organizer and you have 100 people that you can recruit, you can keep a separate communication with them and just take your cues from us here. And then that would be better than having them join the group, because it's going to be a problem with capacity at some point. So if there are people here that represent the same organization, maybe just select one person to attend the meetings, and then the other people would just basically get the feedback. I think that's the best way.
And Dr. Rana is asking, when can we start using the app?
By the end of this week. They've been working on it for the last 3 weeks, and it's at the point where it's almost ready for deployment. They've been working on some of the kinks. So, but it has already a lot of the functionality, which is basically you sign up online. So you'll make it easy. You sign up online. Initially, it's going to be like you're going to have to go on Safari or on your smartphone on the internet. It's not going to be an app on the App Store. It's going to take a couple of weeks to get to the App Store or to the Android store or whatever. But initially, you just go. You're going to be able to just go on the internet on your phone, and you're going to basically put a link, and then that puts you in. That takes you into the system. But ultimately, it will be an app in the App Store. That just takes a little while to get there. What was the other question, Dr. Rana?
Yes, so yeah, questions are coming in, and so I'll just quickly take this one, how we could make groups and organize them, and work on one agenda. So I'll be sharing insight from the need and preference survey that we sent out. So if you've not completed that survey, please quickly complete that. So I'll share additional insight on, about regions and how we're going to move, and I'll obviously run all this through Dr. Mitchell. And so I just want to give us heads up. We're planning. We have to be comfortable with ambiguity. And we welcome, all ideas are welcome. We're just brainstorming at this process. A lot of things are still not clear. So, and we look forward to working and learning from, everyone. So Dr. Mitchell, there's this question. What is the backup for people who don't have a smartphone or internet access? Do you want to quickly chime in on that?
That one is tough. I think the old-fashioned way, which is phone calls, and that just makes it more. I think that's just going to require more people. But I obviously, by no means do we abandon those people. I think you're just going to have to do what you have to. All of this stuff can be done without an app. It just takes more people to do and more time. I think all the app is doing is just kind of one person can handle 30 or 40 or 50 people, whereas if you don't have the app, that one person could probably handle maybe 10 people, because you're going to have to call them twice a day. You're going to have to. So that just the time that it takes to get back to them, to follow up, to call them, it's just more time consuming. Now you could just recruit more people for those people. With Ebola, that we're actually visiting people. We're not going to do that with this virus because obviously we're just going to be exposing those workers. But as long as they have access to a phone line, whether it's a hard line or somewhere to communicate, whether it's a phone or email is actually fine too. If you can tell them, email me, get a Gmail and email me twice a day with your symptoms. If you don't email me, I'm going to watch. But see how much more that takes, because then you have to be worried about getting an email. And so it's more complicated, but that's okay. I mean, there are people that don't have access. The people that are going to be spreading this in the future are not the people that are necessarily in the system. For example, we talk about, the people that work in the fields, the people that don't necessarily have documents and they're hiding, they don't want to get tested for this. And so that could be the next wave that comes. And so we need to reach out to them, and they may not have a smartphone. So yeah, absolutely.
Yeah, Marianne, does that answer your question? You can mute and make contribution if you think. Marianne, are you there?
Yes, I had to unmute. Yes, that does, because I actually have friends that do not have a smartphone, and I just wondered what our workaround was for that, because basically a lot of people are going to be lower income and they may not have smartphones.
Yep. Yeah, no, we have to definitely. I think the way to go around that is that we should have a plan of what happens. What do we do? What are best practices, so that we're all clear. This is what I need to do. And then as you go, if you say, wow, this is not working, I'm asking to send me an email. These people don't even have access to internet. How are they going to send me an email? Okay, then let's get a neighbor. So we come up with whatever works, and we just use that. That's the best way.
Awesome. Thank you so much. Dr. Okocha said we're still developing the app. I think, yes, that's correct. I think we're still developing the app from what I heard from Dr. Mitchell,
yeah.
Right? And we have questions around next steps. How often will we have meetings? and how can we be introduced to the community so that they know that we're volunteers and not scammers? So yeah. So Dr. Michel, I know I don't know if you could give some final thoughts to some of this. I know we're almost.
Yeah, but I'm sure, if you guys want to stay longer, I'm fine. We
Great,
stay a
great.
little longer, unless you will need to sign off, but I'm fine with answering
I'm
questions.
fine. If everyone, depending on what people are doing.
If you need to sign off, you can. I'm going to keep a recording.
Yes.
I'm going to keep a recording, so you're going to get to see this recording with anybody else's questions. If you have to go, that's okay. I'll share the link with the recording so you can listen to the questions that happened after you signed off.
Right. So please, I'm still here, but keep the questions coming, and Dr. Michel will address most of them. Please go ahead, sir.
What was the next question? I saw one about if you don't know any people that are COVID-19 positive around you. I mean, the idea here is obviously that if there's no one around you and there's no testing going around you, there's very little you can do other than maybe work with the closest place to you. I can tell you that the local health departments are fully overwhelmed with this and they cannot handle it. And so whether they admit it or not, whether they want our help or not, is another matter. But I think there's nothing that can keep you from, I can tell you when people start signing up with us, we could assign you, you could be in Alaska being the agent of somebody in Miami. There's no reason why you can't do that. So awesome. You could maybe get some practice with us, with some of our patients, because we're going to need all the help we can get. And then after that, you could start also working with your community. So that's one way to do it. Awesome. I don't think COVID negative people are going to want to sign up for this. I don't see the benefit. We talked about that. Like we talked about, do we make it so that before you sign up for the app, you have to prove that you're COVID positive? We thought about that, right? Mm-hmm. And we said, okay, so it could take somebody a week to get the results back, especially if they get it at some public lab somewhere. And in the meantime, we're depriving them of the benefit of the app. So I think we need to trust when people say that they're positive. Otherwise, why would they want to be reporting their symptoms twice a day? I can't imagine anybody wanting to kind of abuse the app, Yeah. We're putting this app in the Google Cloud, so there will be no issue with capacity. So we could put 1 million people ultimately there if we have to. It's just, there's a cost to that, but we'll deal with that when the time comes. I'm not worried about that right now.
Awesome. So the next question is from Melit. And how do the general population who are exposed know about this app? Is that Team 9 awareness, or would that be yours?
That's right. So we will have several teams promoting it. I think, if you look at the structure of our teams, like we have teams that their purpose is just to promote testing and this type of stuff. So if we could develop those local teams around your area, because there are people that are really good at this. Like, for example, here we have TV personalities, radio personalities, and we're just engaging them. And we're saying, look, you can save your community. We actually got a little lucky because a couple of the people with some of our major TV stations and radio stations had positive people. So they called me in a panic. I want to get tested. I think I have it. So we took care of them. And so after that, they said, how can we help? And that's when I said, you can help by helping us, put out public service announcements. And so right now, like I'm on a show pretty much every day on something different. You could be the local person talking about that. Say, I'm part of this group, with this hospital in Miami, and we're all doing this national effort. And if you want, I'll help you, maybe in the first one, I'll be there with you on Skype, and then after that, you do it by yourself, But we need to kind of do that. We need to put the word out, and it's through the media. And unfortunately, what's happened with the media is that they went from saying that, oh, this is just a bad cold, and we shouldn't be too concerned. But there are 25,000 people that are dead in the United States. So I don't know how you say that. And I think the more people start realizing that, the more they're going to take it seriously. So when you go to the news stations, there are different angles. If you were tested positive for COVID, that's one good angle. You can call and say, look, I was tested positive for COVID. I joined this group in Miami with this hospital, and we're doing this. You know, that might be enough to get them interested in talking to you.
Awesome.
Doesn't guarantee it, but they prefer the death stories. You know, they prefer to have the truck loading up the dead bodies, which helps nobody. It just scares everybody. But unfortunately, that's just the way they are. So, what's the next one?
Yes, thank you for that, Dr. Mitchell. Would it be more, so Dr. Walid is asking, will it be more effective if we identify the positive patient and direct or encourage them and their contact to a number of helplines and group instead of reaching out to them individually? I mean, so if there are people, I think Dr. Walid wants to know, in terms of collaboration, you know, with some other stakeholders already working in the region, how
Yes.
we partner with those within those regions? Is it like send people to the helpline, or other groups instead of reaching out to everyone individually?
Okay, so this is how I feel. I don't know how it works in your community. There are some communities where they may have a solid structure for this, and they may have a hotline where they actually answer the phone and it's not busy. I can tell you that's not the case in Miami. So you call a hotline right now about COVID and you're not going to get anywhere. So one way around that is, you know, if you have the structure of our 10 groups, you can create your own 10 groups in your area and maybe have one representative join our group here to get some of the ideas that they have on how you can reach out to people. For example, there might be psychologists or psychiatrists in your area that are willing to talk to people that are COVID positive. And so I think the more that you can replicate these teams in your local area in coordination with us. So we'll have a team 1 in Arizona that it's composed of people that live in Arizona, but that you know, they're bored. Think about it. Most people right now are sitting at home watching Netflix. And if you told them, look, you can save lives, I think a lot of people would say, yeah, I can call 5 people a day and at least I won't get depressed from just being at the house.
Absolutely.
So I think so. And also there's a huge group, and a lot of them are here now. You know, we have international medical graduates. I mean, there's hundreds, maybe thousands of them that are now, they used to be rotating in hospitals and are now basically not able to go to the hospitals anymore. Or we have MD and DO students, the US medical students that also are unable to go to class anymore and would love to help. So I think all of those people, we should recruit everybody that's willing to help.
Awesome. Oh, thank you for that. I don't know. Deepa is on the line, right? I don't know if he has, because he's been working, updating information on the shared drive. I don't know if he has comments or insights.
Hi, I'm on the line. I'm listening to all the insights.
Awesome. Please go ahead.
Coming to the people who don't have the smartphones, I have a thought. I don't know if that works. They can do a simple text messaging. Maybe we can use the conventional thing. I'm not sure how it works.
Awesome. Text messages, because some people might not even want us to call them, you know, but if we reach out via text, I think, that should work too. But I hear most people are really worried about how could we, you know, I just saw this message from Dr. Rana, you know, how can they identify us as, you know, volunteers and not more like a scam?
I can tell you, out of maybe 1,000 people that we've dealt with, maybe one has thought it was a scam. Like somebody says something like, oh yeah, what happened to all your workers? Did you just lay them all off and now you're trying to get volunteers? You don't understand what we're trying to do. It has nothing to do with the hospital. This is about, you know, helping the community. So there will be people that will meet you with skepticism, but I would tell you 99.9% of the people, when you talk about this, and I think one of the things that you could use to legitimize yourself is just say, look, I'm a member of this team that works at this hospital. Here's an email I got. I became part of the group. So maybe you could show that and say, look, this is really real, and I'm part of that team. And if you want to talk to Dr. Michelle, he's happy to talk to you. I'd be happy to do that, you know. But there's always going to be skeptics, you know, they're going to think we're doing this for whatever reason we're doing it. I mean, we all know why we're here, so I wouldn't worry about that.
Well, thank you, Dr. Michel. I know some people are typing messages, but some equally might want to talk or share insight. So, I mean, you could just say, type in the chat, just say I, then we'll call you up and you share some of the insights. Just type in I on that chat box, and I'll call you up so that you're mute and share your insight if you don't feel like typing.
So next steps, I heard. While we wait, so next steps, the last 5 minutes we'll decide what those are. How often we do the Zoom meetings is up to you. I'm available. I don't know what you think about that, Doctor. Do you think weekly, or I think we should at least weekly until we figure out which way we're going.
Yeah, weekly is perfect. Yes, especially now we're in the planning phase. There's absolutely.
So we have the app is being developed, but it should be developed it should be ready by Friday, is what I'm told.
Right. So I think most of the training will be around the app, if that's what we're using mainly, right? Does that sound like we have to, or do we have scripts or information on the app that will be reading up ahead of really being able to sign on to that platform?
I think the app does have some disclosures and some additional information, but what we'll do is maybe for the next meeting, I'll have the app developers just do we'll spend like maybe half of the meeting just training on the app, so that you know how to download it, how to work with it. I think we should try it to see how it works. Does it work? Does it have the versatility? But technically, somebody in Alaska could be following somebody in Hawaii. There's no reason why you have to be local as long as you have Wi-Fi. So we have about 400 residents in training. So they could be the first people that get assigned. And then somebody had a question about that. So we will be able to move people. So we could say, okay, you're an agent. We're reassigning another agent who's local. So we will have the versatility to do that.
Awesome. Yeah, so let me see. Yeah, so Dr. Walid wants to, make a comment. Please unmute and go ahead.
So I listened to all of the reservations. So the first one was that how do we prove that we are not a scam and that we're like doing an original work. So I had a suggestion that if we could use the Larkin Community Hospital reference in our communications. Second, that most people are like of the view that this forum might be misused by predators or anyone else. So I think I'm a health professional, and most of the people are on here are also health professional or related to health. So we are already bound by the HIPAA certificates and medical ethics to not disclose any of the information already. And the third thing I would like to add is that, like I said, we could direct or encourage people to reach more of the other stakeholders. So why not form like a group of 10, 20 people that are already a group of stakeholders, or like already 10 to 20 people are already forming a helpline, and we could direct the positive patient to those 10 to 20 groups individually. If we could do that, like I mentioned it before, I run a forum called Pakistan Corona Research Outlook. So I already have 20 plus people working around the clock, and we tend to spread the message out as far as we can. And like people already are messaging us or conveying us their queries.
Well, thank you for that insight, Dr. Walid. We'll be, collaborating with you, and just to share best practices from Pakistan. I'll be sending out information, for people that want to be subject matter experts in certain categories, either training or work on the ground. We'll be sending out that information very soon. But thank you for that insight. Gita is asking question, Dr. Michael, about that, about second wave. Do we think we implement all our plan before the second wave? I mean, I think part of the strategy is for us not to have the second wave. That's what our team, obviously, if we could prevent that. But I don't know if you have, more information to share or answer the question.
Yeah, I mean, my feeling on it
10 o'clock
is,
is here.
I'm sorry, say that again? So my feeling on the second wave is that obviously we've under-tested in this country. So I don't see how, with the amount of testing that we've done and the limitations on the testing, that this is going to be over in a week and that somehow we're plateauing. That's just not true. I think we're just deceiving ourselves. And I think there will be multiple waves. I think there's going to be a second wave. I think there's going to be a third wave. And the reason I'm saying that is because everybody's itching to go back to work. And the politicians are saying it's okay to go back to work. So I think it's just, it's going to happen again. And then and the other thing that scares me is that there's no model in the democracy, and then we're talking only according to the countries that not every country has a democracy, but there's no model in the democracy that something that's not repressive works with the level of disease that we're seeing we're seeing a 15% rate on just people that come to the drive-through, which I think is pretty alarming. It's not 1%, it's 15%. So. And what's more scary is that the people that when you look at these 700 people and what they were doing, it's, there were barbers, there were doctors, there were nurses that worked in ICUs in hospitals here, and they were allowed to work like that. And they were told that they didn't need a COVID test, and they were coughing, and they had a fever, and they had all the symptoms. And they would just, unfortunately, at least in our area, I can't speak for Pakistan or other parts of the world, or even the United States, but I can tell you for our area, the healthcare providers have been very listening to whatever the politicians are saying. Our main hospital here, Jackson Memorial, which is where I trained, we had at least 3 people die. One was a nurse that was in ICU, and I've been telling them that to use rapid testing, because we have the 24-hour turnaround time, and they've been sending their labs to Quest or LabCorp, where it takes 10 days to get results. So people get sloppy, and they get the disease. At another local hospital here, 2 young nurses just died. At Palmetto General Hospital this past week, and they were complaining they weren't getting enough personal protective equipment. So whether that's true or not, I don't know. But, when you have a 30-some-odd-year-old person that leaves a 4-year-old kid that gets COVID and dies, I think that's worrisome. And she's one that could have been saved with our app, because it turns out that her husband said that she was really tired. She went home, and then he just found her dead. So if maybe she had the app, she would have been able to say, I'm short of breath, and we could have probably saved her. And a 4-year-old would have his mother. So I think this is going to be a lot worse than the politicians are saying. I think that we need to do this,
Well, thank you, Dr. Mitchell, for that insight. A lot of, mortality, healthcare workers around the world. I mean, we're the front line, and this is really very difficult. I just wanted to get a sense, in the typical contact tracing, very typical, they're usually boots on the ground, but it appears most of our activities are going to be done virtually, mainly remotely. Would that be, or are we going to have some level of boots on the ground?
I do think that we're going to need boots on the ground for one specific population,
Okay.
and it's the undocumented aliens.
Okay.
Because I don't think, number one, they want to get tested, and and I think they're afraid that they're going to get picked up and removed. And I can tell you, our experience is we handle the kids that the kids that are separated from their families. We provide the mental health services for them. And there's a lot of families down in the Homestead area that I can tell you they're probably spreading the disease locally and nobody's doing anything about it. Right. There's another clinic in Palm Beach County called Caridad Center where ophthalmology residents provide free services. They do free cataract services and stuff like that. And they called me the other day. They wanted to see how we could do testing for them. And it's just that we don't have the capacity to test so many people. They're like 2 counties away. And the local county, even though they started about a week ago, 2 weeks ago with a drive-through, it took them way too long to start it. Does someone who's undocumented going to show up at a drive where there are basically uniformed officers from the National Guard? I don't know that they would show up there. And I think those are the people that we need to go see.
Awesome. Yeah, most vulnerable population, especially the undocumented immigrants. Yeah. So we'll make a note of that. And I think you've answered most of the questions, and I will have to start putting, getting us a little bit organized by groups based on expertise on where we think key skill sets are. And Dr. Rana wants to know about goals till our next meeting. Dr. Mitchell, what will be some of the goals you have in mind, some of the things we should come back to you with by our next meeting?
I think let's definitely get the tools that Dr. Walid is going to help us upload. And okay. Let's see if by the next meeting we have, let's say you want to do the same time, or actually, does this time work for everybody? Because I know some of you are in the West Coast.
Yeah, I'll send out a survey just to get a sense of that subsequently.
Okay, so we'll send an invite for a Zoom meeting next week. The goal between now and then is to try to refine the tools. Let's work with what Dr. Walid's tool in Pakistan and see if there's any other tools that we can adapt, at least for the contact tracing piece of it. And then other than that, and they just keep recruiting volunteers. Not necessarily, obviously they can participate in the meeting if they want to, but more just for you to have a group of people that you can recruit around yourself that could help you. And then the third thing would be get a little bit exposed to the app. I'm hoping by next meeting we're going to be able to play with it, download it, see how it works, and get a little bit better feel for it.
Awesome. Thank you so much, Dr. Meko. I'm just wondering if we have any final thoughts anywhere before we wrap up. Any final thoughts, anybody? I think, yeah, Dr. Meko, please, just final closing thoughts and suggestions, yeah, comments. Yeah.
I think Dr. Ran is asking for COVID Fighter for the app. Yeah, those are all great suggestions, but what to name the app, that's great.
Yeah, so we're looking forward to working with everybody. I love the enthusiasm, and this app is going to be a game changer, and we're looking forward to getting more information from Dr. Michael once that's available. And please watch out. I won't send a lot of emails. I will want us to be using the Google Drive that we have at the moment. We might have to transition when we get more information about, resources at Dr. Michael's, hospital that we could leverage. But for now, we'll continue using the shared drive we have. And, this is very exciting. And, I look forward to working with everybody. Thank you so much. I'm learning from you all.
Thank you, everybody.
Yeah. Thank you and have a nice day. Yeah.
Nice day.
Bye. Yeah. Bye.
Thank you.
Thank you.
Yeah.
Thank you.
Yeah, thank you.
Thank you.
Bye-bye.
Thank you.
Thank you.
Thank you.